Hello, and thanks for joining today's session in LHSN's Safer Care Accelerator webinar series. My name is Dee Dee Thompson, and I'm a policy fellow here at Imperial College's Institute for Global Health Innovation, and I lead on the LHSN program, which is a joint initiative with the World Innovation Summit for Health. We're pleased to be joined by two members of the IGHI family today, Erik and Kelsey Flott. They'll be discussing the future of incident reporting and how to make the most of staff-reported data based on their research into the National Reporting and Learning System here in the UK. So I'll just give a very brief introduction of our speakers before we begin the session. Erik has both a private and NHS practice at the Royal Marsden and is a clinical senior lecturer at Imperial College London, as well as an honorary consultant surgeon at Imperial College Hospital, NHS Trust, and the Royal Marsden. He completed a PhD thesis evaluating quality of care in surgery with emphasis on improved techniques for appraising surgical performance and outcomes. And he continues his research in this area here at the Center for Health Policy. Kelsey is a research fellow at the center, working towards her PhD, and works on a broad portfolio of research relating to patient experience of care and patient safety. So without further ado, I will go ahead and hand it over to Erik and Kelsey.
Thank you very much, Dee Dee. Good morning, everyone, or good evening, depending where you are in the world. So, just to give a little bit of an introduction, the National Reporting and Learning System in England was set up by the National Patient Safety Agency in 2003. And it was set up very much with a sort of a broad but shallow net, trying to engender people to report all kinds of safety incidents within the national health system in England and Wales. Reporting levels have generally gone up over the years since it was set up, and now we have over 12 million safety incident records within the system. Typically, a report is submitted about every 35 seconds at the moment. In 2013, NHS England, which took over from the National Patient Safety Agency, took over responsibility for running the NRLS system, asked Imperial College London, particularly the Centre for Health Policy, to carry out a research and development programme to really look at three areas of the NRLS since it's been in place for about 10 years. It was we were asked to reflect on the existing system. We were asked to see whether we could enhance the analysis of the data held within it. It's a very rich resource. I know that there are over 12 million records. Some of the learning hadn't really come out of it as much as it could have done. So what could we learn from the information that was held within it, and how could that inform a future vision for a new system? And we're also asked to explore opportunities for innovation and improvement, particularly thinking about how technology and behavioural insights have become more embedded in the healthcare system. Could we translate some of those into a future enhanced patient safety system nationally within England and Wales? So we did this using four domains of work, and these domains were chosen based on really the evidence gaps within the system. Therefore, it would not only just inform the NRLS in England, but also be pertinent to incident reporting systems more widely and particularly globally. So we took a number of methodological approaches within the four domains of work, which you can see on the slide set there. The approach was very much a multidisciplinary one. Within the Centre for Health Policy, we have a number of qualitative and quantitative researchers, policy analysts, computer scientists, designers, clinicians, academics, psychologists, and we very much brought the expertise of all these stakeholders together. So domain one was really focused on the purpose of incident reporting. Domain two was looking at the existing system and using heuristic evaluation to look at the user experience and what reporters wanted more out of a future system. Domain three was very much focused on the data analytics, so diving deep into the data that's already held within the system, what added value could we get out of it. And domain four looks at a very important area of effective feedback and learning, something the existing system hadn't done very well to date. So moving on to domain one, I'm going to hand over to Kelsey, who's going to take you through domain one and domain two.
Great, thank you, Erik, and thank you, Dee Dee, again for hosting this webinar. As Erik introduced, we had four domains in the NRLS project, and the first one really set out to understand understand what an incident reporting system should do and what it could reasonably achieve. Because the NRLS is the National Reporting and Learning System, it was very important to us to understand what it could do in terms of both reporting and learning. So we set out to do an international kind of expert consensus building process, so using a Delphi model, which basically engages all the experts in patient safety from around the world to understand what they think the priorities for an incident reporting system are and what the incident reporting system can do. As you can see, we spoke to people from the US, Australia, UK, Canada, and the Netherlands in the expert interviews. And so that started off the first phase of the Delphi. There was actually 4 phases of it. And I should go back a step because actually there was a literature review process which helped establish what the main questions would be to ask the experts. During those interviews, we covered these points, which were about the roles of reporting systems, but actually also the methods to maximize feedback, understand how we could collect data, what the difference is between voluntary and mandatory data collection, investigation of incidents, and the data quality that actually the incident reporting system produces. So moving on to what reporting systems can actually achieve, the experts identified the roles of incident reporting systems and also what they can't be expected to achieve. So that is mostly around identifying safety issues, detecting events, but what we critically want to make sure that incident reporting systems don't do is create some kind of benchmarking system or identify unsafe hospitals or use to kind of rate and rank things in a non-robust way. So that goes through the first bit of the Delphi. Moving on from that, we also wanted to understand how we could maximize learning and what the priorities for that were. So that was about not only just understanding the type of data we could use, but also understanding the role of how staff use the system. So things like keeping reporting anonymous to avoid fear of blame and accountability around that, but also to share data and to make that data available for learning more broadly. But also, and we'll move into this more, but to educate staff and engage staff with the process of incident reporting so everyone knows what their role is and what is happening with the incidents they report. A really big piece for us and what came out really strongly in the whole process, and I think we'll talk about actually across all the domains, was the difference between local and national reporting and what the goals for both of those are. So in terms of local reporting, that can be very useful for things like device failures and the types of incidents that are wholly preventable. So never events, hospital-acquired infections. This allows local sites to really target their improvement strategies. But then at the national level, what we kind of identified as something to really encourage was actually the sharing of solutions rather than the sharing of those kind of small, low-level problems. So there's a goal for both the national and the local level, but it might not necessarily be the same.
Just in terms of, just to fill in some of the methodologies, expand on that. So in terms of the Delphi survey that was sent around, we came up with 58 statements, which we put to 30 international experts. Those statements came out of the semi-structured interviews that we held with the 14 international experts as well. We got consensus on 40 of the statements, and we got near consensus on a further 7. Before distributing the survey, we set the consensus level at 70%. So that was the agreement we wanted before we said that the statement was accepted. Of course, there are some areas that we didn't get consensus on. And so, as Kelsey said, although there was a feeling that some instances should be reported in a mandatory way to the national level, and those instances were ones that the experts felt we could find solutions to at the national level, things like never events, hospital-acquired infections, device failures. Equally, the experts would not then commit to an absolute defined set of incidents. So there's still a little bit of tension there between what should be mandatory for reporting, and therefore we feel that they could be used to identify the incidents at a national level, very much from a governance reporting system, versus things that could be reported in a voluntary way at the local level. So we got towards consensus and trying to distinguish this distinction between national and local, but I don't think we completely got there. I think that's an important thing to recognise.
Mm-hmm. Definitely. So moving on from that, after we've kind of established what the role of incident reporting should be, and what we also wanted to set out to do is understand what the user experience is with reporting systems. So to actually engender more reporting and more effective reporting, we needed to understand how people are actually using the system. So this actually took quite a few different studies to understand what people and different types of people were doing with the system. The main output of this domain was mostly for the design and the development of a more enhanced reporting system, which we will go into at the end of this presentation. So in order to inform that design, we undertook a few specific evaluations to understand first the patterns of reporting and reporters, but also their needs, and to gain greater insight into the user technology and interface, but also to understand how they engaged with it and how they understood the reporting system. So what we came up with first was a survey that revealed a huge range of barriers and facilitators to incident reporting. I think some of you may have actually seen this image or something like it before, which is what we've identified as the main problems to incident reporting. And as you can see, there are quite a few that are about the interface or are about the actual technology behind the system. But there's also a lot about user roles and understanding what is actually going on with their incident and the feedback that they're getting from a risk manager or someone who's actually in charge of dealing with the event. So following that survey, this goes over a few more of those barriers. And I think the important thing to point out here is while we have that fear of adverse consequences as the thing that was identified the most, actually a lot of the other barriers to reporting are quite similar in terms of how people have scored them. So we wanted to make sure in this stage that we not only understood the culture and the fear side of it, but also understood the technology, the organizational kind of patterns that might influence reporting, and how users understood incident reporting in general.
I think this slide is particularly important to the webinar today, because the evidence you're seeing on this slide is very much an international assimilation of evidence. So this is taking 110 articles looking at barriers to reporting with 30,000 participants, 4 continents, 20 countries. So this is not something that's just pertinent to England and Wales, it's something that's pertinent to all of us. And we can see that the same patterns come out no matter which patient safety reporting system you're looking at. It's not just about the fear, as Kelsey alluded to. There is equal weighting to all these other important elements or enablers and levers that are currently not working to facilitate people to reporting.
Yep. So then we wanted to go into the specific insights about what we could achieve and how we could improve that. So what are the best kind of design principles to facilitate a better incident reporting system? So this was more about the value stakeholder chain. So what the actual reporters need and their motivations for reporting. But what we found was also a lot of people who used the system were confused about what their role was, how to use it, what to report, but actually also just lack of training around what the system is, which really influenced their willingness to report and to engage with the system.
And can I do a quick interruption? We've got a question from the audience from David Grayson down in New Zealand. So hello, David. His question is, did you sense that some organizations were more open with reporting than others? And was there any correlation with just culture of those organizations on safety culture surveys? And if you came across anything like that.
So the simple answer is yes. We very much see and we'll see a bit later on in some of the data analysis work I'm going to present, that the safety culture between organisations very much varies, and that, yes, that very much influences excuse me, individuals' views to facilitators and barriers to reporting. And then just going back a couple of slides, this is why, having done the local level survey to identify these barriers and facilitators, this was across the east of England and the southeast of England, so a huge area, we wanted to make sure that we sort of factored out that potential variation between organisations. And this is why we did the systematic review and assimilation of evidence globally, and we see the same patterns coming out. So it's not just about people having issues with the technology and interfacing with technology. There is a deeper or more fundamental issues around people's understanding what they should be doing, who and why, essentially. So yes, we do see differences across organisations at a sort of a micro level, as we're thinking about it, but across the macro level, across the system, fundamentally the issues are the same.
Yeah, and I think our next slide builds off that quite well, because what we then went into doing was much more specific evaluations and heuristic assessments of the processes used to report. So during this, staff kind of walked through the actual forms that people use, and there are 67 design concerns identified with that, 18 of which they thought were critical to actually reporting. But this not only brought out those problems with the design and the interface, but also different staff had different problems with the types of reporting systems, and then different types of staff had different needs for it. So actually there was huge variation in what people needed to enable them to report. So what we kind of identified was, so this slide shows you what were some of the problems that we found with the incident reporting system. Overall, the main confusion was about what to report and how to use the different taxonomies within an incident reporting system, how to classify what they're actually seeing in terms of a real-life event into a reported problem. So also the level of harm was confusing to reporters, so that was identified as the main concern. Also identified some opportunities from this, and one of the main things was that 50% of respondents indicated that they had identified solutions to prevent the same incident in the future. So it's quite a huge piece for the learning behind the incident reporting system, and that if we could actually gain those insights from frontline staff, that we could start to make learning, we could start to share learning and do that more at the national level, as we talked about before. The preferred way of identifying solutions was through kind of colleagues and search engines and research journals, and respondents also seem to be very open to the idea of mobile technology to conduct incident reporting. So that will become much more relevant towards the end of our presentation, when we'll talk about the demonstrator system that we've created.
So there's very much, I think, a quick win here. So having done the walkthroughs, people are itching to share solutions already,
yes.
And the technology as it stands inhibits them. And so I think the opportunities here are around embracing technology and using systems like we do every day, be it on Android or Apple devices or social media for sharing solutions. So there's a technological quick win here for reporters.
Definitely, and I think this kind of covers off some of those design recommendations which we've been talking about, mostly about simplifying the process, using those innovative technologies, and creating interactive feedback loops between reporters and managers and whoever's involved. The last thing really covers off the main finding of this, was that it's not just about understanding how the reporting system looks and what it does, but also making sure that people know what to report, who to report it to, and when to report it. So that was really the main outcome of this domain.
Yeah, I think that we need to work towards this idea that we are matching the user needs of the reporter to the functionality of the interface they're reporting into. And you can see from this slide that, you know, the types of incidents that medical staff are tending to report versus nursing staff, for instance, that's a classical distinction. their needs of the questions they're going to be required to fill on the system are very different. There's no point in putting redundant questions in there that's only going to frustrate people and potentially disengage them from the reporting process. So we need to start matching these idea of personas and their experience of reporting in a much better way. The idea of asking the right question to the right person at the right time. This will create a much more enhanced user reporting platform going forward.
Right.
So I'm going to go through domain 3 and domains 4 now. Domain 3 was, just remind you, was very much looking at the data quality analysis. So what added value could we get from the data that was already sitting within the NRLS that hadn't been used as well as it maybe could have done to date. And there were 3 areas of work. It was very much to assess the characteristics and validity of the current NRLS dataset, particularly looking at how we classify incidents and exploring opportunities around free text analysis. To assess the NRLS against other measures of performance at the organisational level, and that's very much come back to the question earlier about opportunities of maybe measuring culture across organisations, and it's for opportunities to create better intelligence about incidents for sharing. Overall, we found that the structured data fields within the NRLS were poorly completed compared to the free text section. So people wanted to type freely. They didn't want to be forced into trying to choose between different things or what the system was trying, how the system was trying to direct them. This is very much true for instant classification. We heard Kelsey mention that in the domain 2, where people struggled to classify instants. And on the screen, you'll see some graphs just to give an example of it. So if we take a random organisation, this is the graph on the left-hand side, and this is not Imperial before you think it is. We take a random organisation, and we look over the years, we see that when people are trying to categorise using the existing NRLS taxonomy, they are struggling. And you can see that because in the majority of cases, they're choosing other as the category. And you say that's not something that's it's not something that's constant over time. It's actually getting worse. So people are struggling more and more with the system. You might think that actually, as the severity of the incident goes up, people might take more care in trying to enter accurate information. But if we look at the same organisation, this is the top right-hand side graph, we see that if we just take out incidents categorised as severe harm or indeed death, other still is the most frequent incident category that appears. So it no matter what type of severity it is, people are still just choosing other, assuming that they can't find the category they want to or don't want to. If you think we've just chosen a bad organisation, we look at the bottom right graph, that is the same information across all the trusts within England and Wales. So we can see this is a common problem across all organisations. We found similar findings for the reporters themselves, indicating who they were, their status. And so if we look at the left-hand side graph here, sort of the lime green or light green bars are where people haven't defined who they are as a reporter. And we see that for about 80% of cases, that's what they enter. Again, the same is true that as the level of severity goes up, so if we move from the left-hand side column towards the right-hand side column, they're still using reporter not defined as the most common entry. What we can take from this bar chart, if you look at the red bars, which are the nurses' reporting rates, they are the most common reporter in the system. But equally, as we move from left to right, as the level of incident severity goes up, you see that the dark green bars actually increase in their height, and that's medical staff. So medical staff are tending to restrict their reporting to the more severe or death cases. So we then looked to free text analysis to see whether we could add value to the problems we've had with the analysing and aggregating the structured data sets. But this in itself created challenges, mainly because reporters use abbreviations, medical jargon, they don't spell very well. And the length of data entries varies hugely. So you can have something from one word like fool to over 1,000-word rant about all the errors that happened or potential errors happened within an instant. And the illustration here, just to give an example of this, so we looked for all the various spellings of Clostridium difficile, which is a very well-known hospital induced infection as opposed to acquired infection, and we see that it's about 371 different ways within the system. So this causes difficulty even with free text analysis, because when you're looking for frequency of words to look for association with incidents, of course you have to try and deal with this huge variation in the spelling. Nevertheless, we made some progress using natural language processing, machine learning techniques to overcome some of the taxonomy issues that we've identified already. One area was auto-classifying events, and this is just to give you an example of this. So NIME is an analysis platform which we can use to try and enhance the information we get out of the free text. And just to give an example of this, so if we type in acute kidney injury into the system, we find about 300 incidents relating to that. What this natural language processing does, though, it looks within the free text entries and looks for common word associations. And so, for instance, you can see here that it often finds acute kidney and IV fluids within the same paragraph. And so what it then does is pick up these keyword pairs and ranks them or weights them according to the frequency, and then researches the free text again with these sort of keyword pairs. And you can see that just using this one example, we picked out another 140 safety incidents that actually were describing acute injury, but because they didn't use the term acute kidney injury, we would have missed them using the traditional analysis technique. So this auto-classifying opportunity using NLP, I think, is a very exciting one that we've used in multiple areas, like mental health is another example, for instance. The other issue that Kelsey alluded to earlier was people really struggling to assign a degree of harm to the incident. And so what we wanted to do is see whether we could take that away from people and use, again, machine learning to try from the free text analysis to automatically define a degree of harm. And we used a text classifier, and we trained it. We took out 2,000 random records from the system, and using clinical experts, we then coded that free text using a validated method, and that we actually used a definition of degree of harm for the medical errors international database. Having trained the system, we then ran it again through another 1,000 records, and we can see that when you compare what the clinical coder gave as degree of harm to what our text classifier came up with, we had a good degree of accuracy. So we got our F measure, our error under the curve was 0.83, which is actually very good. So this is very encouraging, and to say, if we can take away the need for people to try and be forced to choose between either degrees of harm or trying to classify incidents, can we do this using just their free text analysis? I think this is an opportunity to really enhance a future system. So moving on, going on to this question about what could the NRLS tell us when we compare it to other data sets that we have within the system. So we wanted to explore whether patient safety incident reports could be used to compare hospital safety, coming back to the question that was asked earlier. The simple answer is no. So when we compare NRLS and look at the association of the number of reports going into the system compared to other structural and process and outcome measures, such as mortality indicators, summaries, looking at length of stay, looking at the number of clinicians or nurses per bed, looking at teaching hospital status, sort of common things that are used in the literature to identify the safety or performance of the hospital, there is no correlation with the number of reports going into the NRLS. What we did find, though, was very strongly correlated, was that the more organisations tend to report, the more the staff within the organisation tend to suggest there is a strong safety culture within the reporting, within the organisation. So safety culture does tend to correlate with the number of reports going into the system, and that very much feeds back to the question that was asked earlier. We have learned from our analysis that actually the majority of NRLS reports are coming from the acute hospital setting. So less than 1% come from primary care, so sort of community care here in England and Wales. And this is really important because, of course, it's not just about what happens to the patient in the hospital, it's about having visibility as the patient moves around the system. You know, we don't, at the moment, we've got grey zones as people translate between the different care sectors, be it community, primary, or the acute setting. So what we wanted to do was see whether we could use other administrative data sets to try and enhance are learning as people transition around the system. And I'll just give you an example here where we use CPRD, which is a clinical data set which captures primary care data out of the electronic patient records. And CPRD has a coverage of about 7% of England. And we link that to HES, which is the hospital episode statistics, and that is our acute hospital administrative record that has full national coverage. When we link these two data sets together, we find that actually if we look at venothrombotic episodes, we can pick up 40% more than we would have otherwise picked up if we only analysed the acute hospital data. So 40% of patients are presenting in primary care having left hospital with their deep venous thrombosis or pulmonary embolus, and we're only picking that up if we start to link primary and secondary care data. So this is really important thinking, going back to the NRLS, we really need to think about how we integrate in a better way or enhance, enable people to report in different care settings to make sure that we have a better visibility, because of course the safety incidents start usually in primary care and sort of escalate as people move through the system, so we need to try and pick that up in a better way. Going on to the last domain, which is effective feedback for learning. So the first phase of this work was to explore the current use of the NRLS data feedback system. So at the moment, there are essentially two ways which the NRLS are producing information for national learning. There is something called the CAS, which produces patient safety alerts, and it has produced a number over the years. These are the big hitters, like putting the NG tube, for instance, into the lung and feeding people, and has come up with a number of steps that now need to happen to try and reduce the burden of harm that occurs to people. The other system for feedback, though, is a monthly, quarterly, or 6-monthly provider, so organisational level sort of report. So it's sort of a single side of a PDF, which essentially says this is the number of reports you've produced, this is the national average. That's the sort of feedback that's happening at the moment. We wanted to see who was engaging in that second feedback process currently. So we undertook a national cross-sectional survey. We distributed the survey to all people within England and Wales that had an NRLS login, and then asked them within their organisations to share the survey further. We captured about 50% of the organisational types in England. The main finding was that, as you see from the graph and looking at the blue bars on the graph, you'll see that towards the left-hand side, the information tends to only filter down and get stuck at the level of the risk manager and the sort of the organisational management. If we move across and look at things like doctors, pharmacists, nurses, those frontline staff whom we're trying to engage and actually want to gain the solutions from, the information is not really filtering down to them. The feedback by the survey was that people found the information was too rigid in its construct, and therefore wasn't really adaptable to their differing needs. Again, trying to align the user needs with the information we're providing to them or asking from them. There's also a strong message about the timeliness of the data. So because these reports are monthly, quarterly, 6-monthly, things have moved on. Investigations have happened. People want the information now to really inform their practice on a real-time basis. And indeed, there was an appetite from the people survey. They want actually to see live data in real time, a bit like you get the news feeds at the moment. So that was something quite interesting that came out of the survey. So to really do a bit of a deeper dive into the clinicians and try and understand how we could maybe better facilitate the frontline staff to use the feedback or feedback for learning, we did a survey just of clinicians and asked them what they felt would be the enablers to help them engage in a national level feedback process. The overall message was there was a strong desire to share their experiences, but only within their peer group, which I think is quite interesting. And you see here in the top part of the slide some of their suggestions. So they only wanted to restrict the information down to the more severe harm and death, and this would correlate. Remember earlier I showed you that clinicians only tend to report those types of incidents anyway, so I think really want visibility around these. They have a strong preference for electronic feedback over paper, mainly via email, and they prefer to see the feedback coming back through a recognised organisation, particularly a professional society such as the Royal College. And as I said earlier, they quite like the idea of having a clinician-only social media platforms, this idea of using technology to share the experience in real time. Of course, we know from this sort of work done before that we can't rely on passive dissemination of feedback only. Just disseminating information is not going to stimulate the behavioural change that we need to engender. And so we look to high-risk industries for lessons on how effective feedback for learning has been created, and because we know that they have created very much sustainable safety information systems. I think they've done it to a better degree than we have in healthcare. So we went through a semi-structured interview process with a number of safety science experts across a range of industries: civil aviation, maritime, energy, rail, offshore production, to name a few on the list that you can see there.
And actually, is it all right if I interrupt there, Eric? We've got a question that very much dovetails on what you were just talking about, from David Grayson again in New Zealand, about how other safety critical industries, like the ones you just mentioned, airlines, nuclear, etc., how they actually share solutions. Not sure if you can recall from the depths of those interviews any more specifics around that, but if not, I can also point David to our most recent webinar with the World Association of Nuclear Operators, because I know we did touch on that a bit there.
Yeah, I can't remember the absolute depths of the interviews, but we can certainly find out. Jonathan Ben was leading on this domain and did the interviews himself. I mean, just not sort of dodging the question, but just moving on to the 8 requirements. I mean, I think some of that will come out of this. It's not exactly how you engage the person, it's about continuously engaging them. So I think in our current view of feedback for learning is about just finishing an investigation and then providing feedback, and that's it, that's the end of the process. It is very much a cyclical event that you feedback, you learn, you change behaviour, you feedback, you learn, you change behaviour, and within that, of course, is sort of the analysis process as well. So I think the main message that came out of the interviews wasn't particularly how you go about feeding back, but it's about the continuous cycle of feedback to engender behavioural change. So from these interviews, we came out with 8 requirements, one of which I've already just mentioned. It's also about having visible sponsorship. So it is very much about leadership, something we hear commonly. It is also, and there's again another tension which when we presented this work last week at our Global Patient Safety Summit, this idea of people want anonymity, because we know from existing studies that helps people report. But equally, if you're anonymous, how to provide feedback for learning. So I think there's an interesting tension again there about maybe at the local level, keeping it identifiable, but then at a national level, you can start to anonymize. I think that's another interesting area to explore further. It's also about rewarding reporters and reinforcing the reporting behavior. Prioritizing resource, you've got to throw money at resource this, otherwise you can't do this on the cheap. And I think there has to be a capital investment up front. And I think other industries have done that very well because they've recognised the importance of this. So involving engaging frontline staff in the safety improvement process. It's again coming back to aligning the user's experience. We've got to tailor the feedback and learning specific to the relevant needs of the individual stakeholders. Got to go in a continuous cycle, as I said, and there's got to be a strong dialogue and forums to allow a dialogue between relevant stakeholders. So we've just, I mean, this is a 3-year piece of work we've done here at NRLS, and we've very much just sort of given a high-level summary in the sort of 25 to 30 minutes or so. I think in summary, we've come out with I think some very interesting findings. Of course, we've asked more questions as well, and we've got more questions to ask going forward. I think although we set out as 4 domains of work, they're very much all interrelating. You see some common themes coming out of all of the domains of work. I think we have got some consensus on the purpose of incident reporting, although, as said earlier, I think there is still some tension about what should be national and what should be local. Equally, what should be a reporting system and what should be a learning system. I think there is a distinction between the two. A reporting system does still engender the idea it has to be mandatory, therefore used for governance, and therefore used to detect the instance of something. And that sort of almost legal governance framework has to be very different to a system that's voluntary for learning and sharing information. So there's an interesting tension there. We've come up with design principles to improve the reporting experience, but accepting that incident reporting is complex. It's not just about making the user interface more user-friendly, making it look pretty with pretty colours. It's about asking those right questions of the right people at the right time. We've got to try and map better the persona, the individual stakeholder, to the questions that we're asking of them to get the most out of them, to then provide the best feedback to them for effective learning. We found some opportunities about linking safety incidents to other data sets, think about primary care, looking at the translation of care, to be able to sort of fully interpret the impact of safety incidents. I think there's some exciting opportunities around natural language processing to overcome some of the issues of taxonomy and some of the subjectivity of degrees of harm assignment. And out of the last domain, effective feedback and learning, I think there's still some further work to do around integrating social media and other dynamic, interactive reporting platforms to engage stakeholders in effective reporting and feedback for learning. So what tangible we got out of this program? Well, we have got a new demonstrator system called Care Report that I'm sure we'll be seeing featuring in a future webinar, potentially, Didi, which is now deployable. So this is a usable live system which is available on Android, on Apple, both as a web portal but also across mobile devices as well. And this, I'm sure we can, through our Global Patient Safety Summit last week, we've got some footage of what this actually entails. I'm sure we can direct you to see it. But this system has been built based on the findings from the research program about what people want and do not want within a system. And I think very much what this has done also is really taken on the whole feedback and learning. So within the system, you'll see the sort of the instant direction of people when they report an instance to other areas for learning. What else has happened in the country around this? What solutions have been found? It's engaging people in social media to share solutions. So I'm sure we'll do a webinar on this down the line to give you more depth. And of course, to say thank you very much. Of course, this isn't my work. This isn't Kelsey's work. This is the work of a huge body of people over 3 years. So very much a multidisciplinary body of people, and we're also very grateful also to NHS England, Mike Durkin, who's the national director for patient safety in England, for his support and the support of his team, which has allowed us to do this, and I think created some impact certainly within England for how a future reporting stroke learning system is going to look.
Great. Well, thank you both so much for taking the time to do this. I realize we're approaching the end of time, but wanted to have time for just a few questions. So we'll open up to the audience, and if you have any, please feel free to go ahead and type those through. But I thought I would go ahead and start, if that's all right. And just as you were saying, this has been, a 3-year journey of work.
Yeah.
And I was wondering if anything came to mind that was particularly surprising or unexpected across really any of the domains, something that you weren't expecting to find.
I think for me, actually, was the focus on just acute care reporting. I have to say, I mean, just to give people some context, so there are a number of ways that you can report into the NRLS. The traditional way within hospitals is that people report into a local system. Datex is a local software platform that's used by about 3/4 of organisations across the country. That information is then cleansed by local risk managers and then fed up into the national system. The other way is people can actually just report directly into an NRLS e-form. So for primary care, there should be a direct way of reporting, because of course we can't expect them to have lots of local risk management systems, but less than 1% of the reports are coming in through primary care. we know safety incidents, particularly around prescribing and things, happen a lot in the primary care setting. So we're just either ignoring or not enabling people to report. There shouldn't be this focus on acute hospital setting. Actually, the least amount of care we provide to patients happens in the hospital. Most of it happens out in the community primary care. And so for me, I think that was the biggest finding that I think we need to address.
I think the most surprising thing for me is much more technical, and that was the appetite that reporters have for actually being able to type out their event and to input the kind of their narrative of what happened. I think we go into it assuming people want something very quick and sharp and drop-down menus, which they do for the most part, but that there's actually an interest in being able to explain the whole story and to give a much more detailed report and to have that opportunity in an incident reporting system, which I think as researchers we might not have expected going into it.
And just sort of one final question, and then we'll wrap up and thank everyone once again. Just if you had, one or two key takeaways that you would want participants to walk away from, sort of high-level messages, any kind of conclusion, what would you say?
I think for me, it's about this journey we're going on in terms of restricting at the national level what we have to report. Because as a clinician, if I hear the word report, it's because normally I'm in trouble or I've got to do something so I don't get into trouble. And if I think we're going to enable frontline staff to really inform patient safety and protect patients, I think we have to move away from that sort of dialogue and that perception at the moment. So I think it is about this national versus local tension. I think we can gain a lot more from people by making them feel part of a local system where they just feel free to monitor or input or suggest, not using the word report in my narrative now, and for the benefit of patients. That's, I think, the most important message from me.
I would agree, and I think the thing that I've learned from it is the importance of sharing solutions rather than problems at the national level and how powerful that can be.
Yeah.
Well, thank you both, and thanks to everyone for joining. I'll also be making a recording of this session if you would like to listen again or share with anyone throughout your organizations, and that is on our website at www.leadinghealthsystemsnetwork.org. So thanks again, and hope you have a great day. Bye-bye.